Well, good morning, everyone. What a great spring day. I think it's finally spring. Although, when we see a few snowflakes here and there, we know we're struggling into spring. But it's just a terrific day and a wonderful opportunity for collaboration. And I think that this particular salon is really reflective of what we value, and seeing our community partners here with us today is very exciting. I'd like to extend greetings from Dr. President Dr. Mayman, who is off campus this week, as well as Provost Deborah Bordelon. We're excited about the research and the scholarship that's occurring here at the university, and this is really an opportunity to bring it all together on a particular topic. And because working with children with disabilities is my particular area of interest, knowing that we have gathered today a group of colleagues who are particularly interested in this topic of environment is very exciting. And as Dr. O'Shea had said, bringing people together to hear the scholarship is important, but more importantly is the opportunities for our students, our community partners, and our faculty to find curiosities and other questions to pursue in our research. One of the things that we know about children, particularly children with disabilities, is the focus is not just on children. Children are parts of systems. And we know that children and their families are who we want to address, and we want to think very carefully about the factors that can both facilitate or inhibit their development. And I think thinking about the environment is a very broad topic, but a very important topic, because we know that the environment is composed of built physical space, natural environments, cultural, societal interaction factors, social and economic systems, which are all very important to children's development. And I think today the group of papers that we have gathered together for presentation are really reflective of different aspects of what we would consider environmental factors. So I can't thank you all more for being here today. I congratulate Dr. Sood and Dr. O'Shea for writing this grant here at the university and giving us a platform and an opportunity to begin the dialogue. So congratulations to everyone for their willingness to participate, and I know that good things will come from this. So I look forward to that. So thank you very much, and I wish you the very best today in the talks.
Good morning and welcome again. My name's Elizabeth Wanka, and I'm actually with the College of Health and Human Sciences, specifically in the Occupational Therapy Department. So I'd like to start really by telling you a little bit about my history and how I got involved in really looking at culture. And so early on in my practice, I began working with Hispanic children within the school district, as well as early education. And so at that time, I had very good outcomes with the families that I was working with. But some of my colleagues that were occupational therapists would always ask me, what is it that you're doing that, why is it that you have such great outcomes? And they wanted to know a little bit more about that. And so because of that, I really started asking myself many questions. And one of those questions was I culturally competent? And was I, what was it about me working with the Hispanic clients? And was it that I was from the same cultural background, which I'm Hispanic? And so that led me into really starting to look at it and question myself. And so with time, I really started asking lots of questions. And at that point, because I was here at Governor State getting my doctorate degree, I really had the opportunity to turn the tables and be on the other side of the table. And one of those opportunities that I had was being able to go to the Ukraine as part of a service learning trip. And so while being in the Ukraine, I actually was able to actually immerse myself within a different culture, a culture that was not like my own. And so from that, along that journey, I developed a model on culture and with diverse families. I've completed a tool, a cross-cultural tool, that really does look at the cultural environment of feeding with children. Both of those, the assessment as well as the model, I had a mentor, Dr. Sood, that helped me with that. Since then, I've actually also done 2 studies looking at parents' perceptions on mealtime participation at the family level, where the culture is, with children with developmental disabilities. Oh, go ahead.
My name is Lidia Huerta, and I'm a bilingual speech-language pathologist and faculty here at GSU. And my interest in bilingual speech pathology came about when I started working as a social worker at the Developmental Diagnostic Treatment Center at Illinois Masonic Medical Center in the north side of Chicago. And it was there where I was first exposed to culturally and linguistically diverse families whose children were either assessed and or treated with developmental delays. And so as a bilingual, bicultural speech-language pathologist, I've continued to expand my interest in this area. I assess and treat individuals or children whose teachers or parents are concerned as to whether their language skills are due to a dialectal difference or is it a true communication disorder. The other aspect is looking at families within early intervention and looking to see their cultural difference compared to what we as clinicians in early intervention bring to their home as far as assessment and treatment approaches that address developmental skills. And looking at how we facilitate, as Dr. Cada had mentioned, how we facilitate or inhibit the progress of their development. So as we continue, for those of us, we recognize that some of you, our audience members, may not be familiar with the field of speech-language pathology or occupational therapy, so we're going to touch on our fields very briefly. When we think about a communication disorder is present when an individual has difficulty, significant difficulties with communicating with members of their community. So we look at how they communicate or have difficulties communicating with individuals who share the same language, the same dialect, and or the culture, okay? And so when we look at communication disorders, we look at various aspects of communication. We look at speech disorder, and how does the child use or not use the speech sounds that should be present within his or her speech community. Language disorders, looking at how the child understands the language within his or her speech community, or how does the child use the language within their speech community, and where is the breakdown. When we look at social communication, we look at the rules that apply to social communication. Along with that, we think about greeting, rules that tell us how to greet, how to take turns. And we know that different speech communities have rules that tell us how we should communicate. So we identify and assess and treat those skills as well. And then swallowing disorders, difficulties with feeding and or swallowing edible substances. So Dr. Wanka is going to tell us about OT.
So occupational therapy. Occupational therapists work across the lifespan with individuals have been diagnosed with a disability or delay. We also do prevention within the community. So here you see at the very top, we actually look at occupations. And when we look at occupations, we look at anything that will occupy your time. And so, for example, it may be something like grooming. We all get up in the morning and we have to groom. Or it may be dressing. It may be with children. So for today, looking at play. And so bringing, for example, a child through their developmental milestones or adapting their environment for them to be able to play. We value the person doing the activity and how the environmental influences our choices. And so via occupation and asking individuals what is meaningful to them, it's very important because through that, we really find out what is motivating to the adult or the child that we're treating. And so it gives meaning to what they're doing and what we're working on together collaboratively as an occupational therapist and the individual that we're working with. So clinical implications to our practice. So why is it that we're speaking today, and what are maybe some of the problems that we see? So cultural factors play a significant role in the day-to-day experiences of the families and the children who are part of culturally diverse populations. And as you see, the evidence really does reflect that. And with each interaction that we have as occupational therapists or anybody that is delivering service to these children, we know that the basic part of this is looking at the individual's culture with every interaction. When the service provider is unable to understand the connection between the person, the family environment, and the culture, there's a disconnection between the needs of the client and the service provided.
And so when there is a disconnection, when we lack cultural awareness or cultural competency or cultural responsiveness to the families that we provide services, we risk an overrepresentation of these children being placed in special education environments, or an underrepresentation of these children in gifted or high-achieving academic programs. And so it's very important that we become culturally competent and aware. And so before we talk about cultural competency or awareness, we're going to talk about how we define culture.
Mm-hmm. Oh, so here you see the 4 stages of culture and how we're going to define it today. The first stage of culture would be the regional level. At this level, we're really looking at the language spoken and the ethnicity. The second stage that you see here is the community level. At this level, we're really looking at the socioeconomics of the family that we're looking at. And so the third one would be the family level, and that's where really most of my research has been done in. And so at that level, we're really looking at who is it that's within this family. Are we looking at only the nuclear family, or are we looking at the extended family? And the individual level. At that level, we're really looking at the uniqueness of what each individual views and what their personal values are.
And so at all of these levels, we look at culture as a behavior, belief, or the values that they have in common with the community that they are part of, that they are members of. When we think about culture, we think about shared rules, a collection of shared rules for what we consider appropriate behaviors that individuals who are part of that community need to learn and use to be effective members of that cultural group. As children develop language system, they develop their language system and developmental skills within that context of a culture. And so we look at culture as the foundation or the lens in which they learn language, in which they develop their skills and they develop milestones. And so one of the things that we want to ask ourselves is, what lens does this child of the CLD population, culturally linguistic diverse population, I'll just say CLD, what lens does this child have that helps them interpret, perceive, and understand his or her world? because we say in our field of speech-language pathology that our word knowledge is based on our world knowledge. And we can say that about all developmental skills or all developmental areas. Along with this, Edward T. Halls in 1976 developed an analogy on culture, and he called it the cultural iceberg model. And so when we look at culture, oftentimes as clinician or health organizations, we look at the observable behaviors, the explicit behaviors, which often are the food preferences, the language, the dress attire, but we're challenged as clinicians and health organizations to also look at the non-observable or implicit behaviors, which in order, according to Hall, in order for us to really understand the individual's cultural background and cultural values and beliefs, we need to have a good understanding of these non-observable behaviors. And some of the behaviors that fall under this category include age and gender roles of the family, child rearing practices, values and perceptions, and exposure to and adoption of other cultural norms. How do they assimilate or acculturate to mainstream society, and how do they value that? So one of the things that we look at is a cultural competence continuum. And we challenge our clinicians and health organizations to ask ourselves, where am I? Where are you as far as your level of cultural competence and awareness and responsiveness to the CLD population? And in this continuum, we see two very different extremes, from cultural destructiveness to advanced cultural sensitivity. And I'm just going to highlight how we define three of these levels of the cultural competence continuum. Cultural destructiveness are attitudes or perceptions or practices which are destructive to cultures and, in essence, to individuals of those cultures. These individuals or organizations that fall under this level do not value diversity, and instead they develop programs specifically to limit access to certain populations. Okay. Cultural blindness are clinicians or healthcare organizations who think that they are unbiased, who say, I don't see differences. And while that may sound great, I don't see cultural differences, they're not taking into account the cultural strengths and richness that the individual brings to the table, to their clinic, to their setting. And oftentimes, this leads to blaming the client for their own problems. They assume that anyone can access my services. But this cultural blindness leads to a lack of modifying or adapting their service to that certain population. A simple example, and Dr. Wanka will provide us a few other examples, but changing our oral and written form of communicating either to the hearing impaired population, to the visually impaired population, and or other CLD populations. And they believe that if my service is effective for this group, it will be effective for everyone. So we negate cultural richness and strengths with cultural blindness. Now, those of us who desire cultural competence and awareness and being responsive, we all desire to be advanced, to have this level of cultural competence, which is advanced cultural sensitivity. And this is a clinician or health organization that is willing and makes a very strong effort to adapt and modify their practice based on the community that they serve, okay? And this is a group or an individual that will desire a deep knowledge, and by desiring that deep knowledge, they will do research and use that research to modify and make changes within their practice to support the population that they serve.
And so we also wanted to make sure that we defined culture at the family level. When we define it, the family unit may consist of the nuclear family. The nuclear family is a group consisting of a father, mother, and their children who share the same residence. In addition, the extended family consists not only of the basic family unit, but extends to include adults and children with kinship ties. Extended families can include grandparents, spouses of children, cousins, aunts, uncles, and those that are associated by religious beliefs.
When we look at literature on families and culture, we recognize the impact of interdependent societies versus independent societies. It's thought that mainstream American or Euro-American culture emphasizes individualism. When we think about independent society, and the mainstream community, we think about individual fulfillment, where independence, autonomy, and self-sufficiency is emphasized and encouraged. Whereas in interdependent societies, which many CLD populations fall under, do not focus on individual fulfillment. Instead, they look at the well-being of the group, the family unit, at the family level. And so they encourage they value my role within my family, and they see that family is responsible for the child, and it's often the extended family that's responsible for the child. Maschinite summarized a study that they asked individuals to complete a starter sentence, and the starter sentence started with I am. And they found that individuals who come from interdependent societies will complete that statement with I am a sister, I am someone who takes care of my mother. Whereas individuals who come from independent societies will complete that statement with I am athletic, I am intelligent. So very different ways of looking at themselves as members of the society.
So when we look at children, we actually have to look at that the predominant resource for children are their families, that family environment. And so that's where they actually learn their values and their beliefs within the family unit. Familialism is part of that. Sometimes when we talk about westernized versus non-westernized views, we really have to take that into account. And so familialism is a strong bond. And so one study in particular pertaining to feeding reflects the amount of Hispanic mothers versus Caucasian mothers and the level of assistance during feeding. So the study actually concluded that 84% of Caucasian mothers encouraged their child to self-feed versus Latino mothers, only 4% encouraged their child to self-feed. So the takeaway from this isn't really about the feeding piece of it. It's more so about that the Latino parents really value this familialism or the concept of interdependence. And so when we look at interdependence, we actually, it's not just unique to the Hispanic population, Latino population. It really can be part of the family and what they value from different and distinct cultural cultures. And so one of the other cultures that I researched was the Japanese culture. In their culture, they also look at the concept of interdependence, and they actually call it ame. So it's important as clinicians to really take that into account and really ask the questions that we need to be asking when we're looking at that family environment. So some of the unmet concerns with families. So evaluators run the risk of making incorrect assessments if they interpret the client's behaviors by what the mainstream culture is. And so that's when we're looking at, because the United States is such a melting pot of diverse cultures, that we actually have individuals that believe in that have non-Westernized views, so we always have to take that into account. In fact, using inadequate tools may exclude individuals of diverse cultures from accurate developmental assessment and from participating in meaningful occupations. So some of the strategies that we'd like to share with you today, strategies used by culturally sensitive and competent and responsive professionals, because it is always a collaborative effort with families. It's not only, for example, the occupational therapist or the speech pathologist or any other individual that's in the service delivery industry. It's really all of us really should be doing this. And so one of it is really understanding knowledge of self. We really need to understand our own underlying values and biases. That way that when we actually do work with these families, we can put those to the side and we can actually be client-centered or family-centered. Knowledge with other cultures, customs, and beliefs and values. We have to actually ask many questions and find out what are the values, because we don't want to go in and have, even for ourselves, have the biases that everybody that pertains to one certain culture has the same values. That's why we really have to ask questions about that. And knowledge of language differences, including dialects, is important. Meaningful interactions with other cultures, meaning understanding the family values, the rituals, and the routines. For example, asking questions about who they consider to be part of that family. And so finding out if they really do value interdependence, which is that familialism or the May examples that I had given. How are the decisions made within the family unit? Who's helping the family make those decisions? Is it just the mother and the father, or are they seeking knowledge from that extended family? Spirituality. One of the biggest pieces to understand is really, are they getting any outside spiritual healers involved? Because we know that sometimes there may be some, medications that they may be taking or other things they may be believing in that we really need to know. When working with families that require an interpreter, making sure that you maintain eye contact with the parent. I know when I went to the Ukraine, that was one of the biggest pieces that I, took away, was that many of our students were really looking at the interpreter versus looking at the mother. And the way that we build reciprocity with our clients is by, looking at them and asking them questions, and in turn, then they begin to trust us. Using cross-cultural assessments whenever possible.
And these are just a few examples of various strategies you can use. Dr. Wanka and I have actually had extensive conversations of various strategies that we can use and that we would like to share. That would take a whole nother
Couple of hours.
But in general, what we ask or invite you to do as clinicians, and as you develop knowledge or cultural competency or awareness, is asking yourself or considering, how did I obtain my attitudes and my biases? Okay, what was your world knowledge like as a child, as a teenager, and as adult of who you've become now? And not just clinically, but personally as well, because that will definitely impact, especially when we're going into families' homes or their schools. How did I obtain my attitude and bias? How do my biases impact the diverse, exceptional learner on my caseload? And can I eliminate that bias? Is it possible to eliminate it? And then develop an awareness of social political factors that confront culturally different groups, not just yours, your group, your culture, but also the other culture, and how does that impact your relationship with the family that you're working with. And so when we talk about implications, the first one we have here is education. Developing that research, but also using that research to make modifications, to adapt as a professional, as a clinician, as a health organization.
So another one is interprofessional research. It's very important for us to collaborate because not only as occupational therapists, we need to know what the other service providers are doing as well so that we can all be on the same page. Development, and even further on, development of cross-cultural assessments so that when we're identifying children that may have disabilities or delays, that we're really looking at the family unit and whether they, some of the points that we had today, whether they value interdependence or what is it that the family values. And I think that's it. Is there any questions? Yes. Sure.
In the best of your knowledge,
Sure.
are there tools for pediatrics that are cross-cultural, or are there specific things that we as clinicians and service people should look for that is at least a tool would lean towards
Sure.
cultural
And
versus not?
so a lot of the tools within occupational therapy and even physical therapy that may cross over really do look at for example, like milestones, but unfortunately, and they may be in Spanish or in other languages, but the bottom line is that sometimes they don't really give us a discrete, a view on how the child is performing. So when I talked before about, the child self-feeding, the bottom line is that we can come in and bring, for example, a Peabody, but we're not really going to get the salient piece of, they can't feed themselves, but really are they developmentally, their fine motors developmentally delayed. So there's really not many.
One of the things that we talked about was that compared to OT and PT, there seems to be a little more in speech pathology. We have language assessment tools and therapy tools that look at cultural diversity, primarily within the Latino community as well as the African American English speakers. And so there are tools that have clinicians consider looking at those differences, those dialectal differences, but we have to be cautious when we look at, for example, the assessment tools and make sure that the language sample that was used looked at those populations, because some of these tools are only interpreted or translated. They're not based on the community that you're supposed to be testing on. So those are some of the things that you need to consider. One of the things that I talk about in social linguistics are specific toys or therapy approaches that you can use that are more CLD, relevant to the CLD population. One simple example is within some cultures, animals are considered sacred. And it would be inappropriate for me to take a farmhouse to this home setting to play. And yet, we as speech language pathologists use the farm in early intervention a lot, because some of the first sounds that children learn are those consonant and vowel sounds. And so, meh, boo, or nay are initially used, but that would be inappropriate for some cultures. So identifying, what is the play or social environment like that you can bring to the table. And sometimes what we need to do too as clinicians, we often in early intervention bring a bag of items, but we should see what they have in their community, in their household, and use the materials that they have, or create some with the families, rather than bring some and then take them back with you when you leave. I don't know. Yeah.
Did we somewhat answer?
Any other?
Yes.
What do you do in the cases where the underlying models of your practice are in conflict with the underlying models that describe the problem in terms of the other culture? Let me make that a little more concrete. I realize that's abstract. For example, in certain sections of the Asian culture,
Yes.
conditions are caused by imbalances of energy. So, for example, you can have a energy imbalance that is causing a back pain that then becomes a throat infection.
Sure.
And the practice is then to move it to your feet, have a foot massage, discharge that energy, and the problem goes away. Now that's very different than how the Western culture would view treatment.
Absolutely.
How do you bridge that gap?
So one of those, I had touched on it a little bit within our discussion, and really paying attention and asking the questions, because we can't really say that that's not working because we don't know enough about these things. So trying to actually educate our clients on really understanding what is it that we're doing in occupational therapy, and then taking into account all the other, things that are going on within that family's life is very important. Do you want to?
I think too, finding a balance of being responsible or being respectful of those thoughts and beliefs, and finding a balance of how do I bring my clinical background to help the family with the child with a disability or an individual with a disability. And I think it takes time, and it takes an open mind and open from both individuals, from both parties. And can you find a common ground in which to work with? I think definitely one aspect is demonstrating a level of understanding and respect with that. I can tell you with my culture, my mom used to have a different form of thinking with how to treat some of her ailments. And, I was more under the Western approach. And so how do I respect that, but yet guide her to some of the other methods of treatment? And I think there could be a fine line with that. I think that it could be very difficult, and if there isn't a level of respect, I think, or understanding or compassion, I think you'll lose those families instead of having them, I don't want to say cooperate, but follow some of the treatment approaches that you recommend. So
I have reframed the Western models and just used their language and their analogies to get that buy-in. Do you find an ethical issue with that? It's very effective when I do that. If they're using, spiritual model, then I'll just turn everything that we're doing into, these are the spirits that we work with. This is how we control
I
these
think that's
forces.
a possibility if you understand and are very knowledgeable of those thought processes and the attitudes and how they value. I think asking, and if you're not asking the appropriate questions that lead to an understanding of that. I don't know if you have other thoughts of that.
No, I think that we have to be, when we're working with families, we actually have to put all of our language at a level that they'll understand. So it sounds like that's what you're doing, to really convey what is it that you want to educate on. And so, I think that we all do that as practitioners. Although we have to be very careful that that the education piece comes along with that.
I think this is where that deep knowledge of cultural competency and awareness comes in. Because if that's not there, then to become culturally responsive, which I think is what you're referring to, will be difficult. And I think there has to be a certain level of that advanced cultural sensitivity that has to be present.
Okay. Any other questions? Okay. Thank you.